There's a real parallel between what our thoughts were with starting DCI, and the concept at that point was to make sure that patients had access to all forms of care for chronic renal failure. So that we wanted to do home hemodialysis. Peritoneal dialysis at home really did not exist at that time. And of course, in-center dialysis for those patients who couldn't go home. But we also recognized that part of this three-legged stool was clearly transplantation. And for those patients where transplant was possible, also clearly that seemed to be the best therapy that we could offer.
Began with the program in 1971. The transplant program at VA and Vanderbilt hospitals at that time consisted of a couple of internists, nephrologists, a surgeon, a couple of residents if we were lucky, and a couple of tissue typers. Back then, one of the surgeons had bought a preservation machine, so we went clinical. From there, the dialysis clinic saw a need to support this effort because the procurement of kidneys could not really be handled by staff.
When I first started doing them, I think our age limit was 45, 50, and anybody that was over 55 or 60, you didn't transfer, it was too high a risk. And one Sunday night, Dr. Philip Walker, who was a nephrology fellow here that was a contemporary of Dr. Johnson's, had a patient, and he got a call from Dallas about a donor down there that they had a kidney for Mrs. Clip. And so my usual thing then was, well, how old is the patient? He said, I think she's about 46 or 47. I said, okay, well, just send it in. Well, this kidney was removed in Dallas by a urologist and put on a perfusion system. It took both kidneys out. They got on American Airlines and flew to Houston, got off, took the machine to the hospital there, took one kidney off, got back on the plane, came to Nashville, and you got here about 7:30 at night. Well, when I came in to see Mrs. Clip, I was examining her and everything. I said, how old are you, Miss Clip? And she says, well, I'll be 66 by my next birthday. Well, here I was, I'd already committed to she looked pretty good. And I said, well, I think we've got a kidney for you. Well, Mrs. Clip's husband had taught biochemistry at Davis Lipscomb for years, was retired. And they were very anxious in her to get a kidney. I put that kidney in, and Mrs. Clip, she was 66, I think. She lived to be 86, and she lived to see her grandson graduate from Vanderbilt Medical School.
We thought that if we could find someone else that need not be a physician, but who needed to have medical knowledge to help us in this regard, it would really spare us from doing a lot of these activities, and also spare us the monitoring of patients who were near death, so that the donor process at the appropriate time could proceed. It should be remembered that at this time, there was no brain death law in the state of Tennessee. So all donors died because of cessation of cardiac function, which greatly complicated the situation, the logistics of obtaining the kidneys and maintaining them in a status that would allow successful transplantation.
I called Keith, Dr. Johnson, and told him that I had to do an externship. I think it was 3 months, I believe it was. It was in the fall of '73. And I talked to him, and he said, well, come on up. And so I did an externship there, and that's the first time I met Keith in the fall of 1973. And then I did the externship, and it went well, and he offered me a job to get kidneys.
We interviewed a fellow named Ewing von Schmittu, who had just completed the physician's assistant program at Emory in Atlanta. And he ultimately got the job, and then he would, identify these people as they came in the emergency room and, obtain permission from them and everything.
He thought this sounded interesting, and he came on board and really provided a very important function in this activity so that we could increase the number of donors.
Back in those days, what we did were called non-heart-beating donors. These were donors that were declared dead on the basis of cardiac cessation. Their heart stopped beating. So what would happen in those days, because you had to get the kidneys cool before they were damaged, Ewing would do the nephrectomy right there in the ICU. So the neurosurgeon or the resident or whoever was sent down to take this patient off the ventilator because they knew they were dead, but they didn't want to declare them legally brain dead, would take them off the ventilator and would stand there and watch the monitor until the heart stops. And Ewing would have the patient prepped, draped, everything ready, and when the physician, the neurosurgeon, the resident, or whomever said, okay, go ahead. Howell and I did the organ recovery. We managed the patient listings on the computer, and we did all the donor runs to match the donor organs that were available with the patients. So, and then we also moved those organs around the country. If they had to go from Nashville to somewhere else, Raleigh, Durham to Duke or somewhere, or Cincinnati, or you name it, we took care of that, and a lot of times ended up flying them on the perfusion machines in the company aircraft.
I'm going to cut to the chase. We did, it worked. We went clinical. First year we did 60 kidney transplants. That was amazing because that was probably as many as they'd done in the whole history of the transplant program up to that.
A lot of times we couldn't get the company airplane because it was gone, or James had it booked for a trip in the morning or something like that. So we'd have to charter an airplane. So we'd charter from the local people there at the Nashville airport, and we just get whoever we got then to fly in whatever airplane we could. And we had some interesting nights with those people too.
It was somewhere in the neighborhood of around 1970, I think 71. They were a customer of a charter company that I flew for back in the day. And we started flying kidney transplants around the country back in the early days.
We were bringing a kidney up to the Cincinnati transplant program. And at that time, Lunkin Field was the Cincinnati airport that was closest to downtown. And they called it Sunken Lunkin because it set down in a depression with levees around it because of the river. It was right on the river. We headed on up there, shot the first approach, just blacked out, it was totally fogged in. He said, okay, we'll go around and give it another try before we divert. And immediately, as soon as we touched down, we hit a fog bank. It was just white out all the way around us. And he slammed the throttles forward and yanked the yoke back, and the airplane started to climb, and then both engines quit. And so we didn't climb no more. We hit the ground. It slid off the runway, towards the river, and I thought, oh, we're gonna drown, we're gonna go in the river. And finally the airplane stopped sliding, so I thought, we gotta get out, we're on fire. So he tried to get out the door on the front, and the wing had bent up a little bit and jammed that door shut, so he came over the seat back where I was. We went out the back door. And it took the crash crew maybe 30 minutes to find us in the fog. I ended up calling Tom Tate, and said, listen, we've had a problem up here, I need to get home. And I've got a kidney. He said, can you come get me? He said, oh no, we'll send a Learjet up for you. So they sent a jet up, and we went home and transplanted that kidney.
Well, when I started in 1987, there were 12,000 patients on the waiting list. And now there's over 100,000. And we were doing less than 50 organ donations per year. And we just broke a record this past year and did 433. And transplanted over 1,200 patients.
I think in retrospect, the support I got from Dr. Johnson and Dr. Ritchie and in all the people, I thought about this. Hal Warner was the preservation person when I got there. And then a guy named Carlos was brought on, and then Bob Duckworth, and the tissue typing people, the secretaries. All those people were important in their own right. And the program would not have worked if you didn't have those people.
The most rewarding was seeing the outcome, seeing the families, whether it's the recipient families, the donor families, or the recipient, get something positive out of it. But you know what else got positive was the nursing staff at the donor hospital, the staff at the transplant hospital, who had something that maybe they had to do the attaboys themselves, pat themselves on the back, but they had something visible that they could follow that made them feel warm and fuzzy. And that was what was neat. It was a technology that previously would have been a funeral.
It was a real joy and honor to know that I was doing something really positive for another human being. It made me feel good inside to participate in that and be a part of that.
Having lived long enough to go back to the days when you couldn't even accept those patients to dialyze or to have them waiting for their transplant, you know, I mean, there's no question that it was the right, you know, the minor annoyances, the greater good was certainly served by getting the federal government involved, and that was the only way that the program would have succeeded the way it has. And it has succeeded. You know, we've been a victim, really, of the success of being able to treat patients with chronic renal disease so effectively. Because back in the beginning, you never saw a patient on dialysis with diabetes or even lupus or other medical problems that were causing secondarily their renal failure. Nowadays, of course, diabetes is the #1 cause of somebody who has kidney failure and needs treatment. And those patients weren't even being referred back at the beginning. So the population of patients that could be helped really expanded as the effectiveness of the treatment improved over the years. It's been a phenomenal story, really.